Now you have to share the screen. And you have to do the sharing the screen. Let's say,
good afternoon and welcome to the first CPC of this year. We have two cases this time. One is from our own surgery department and second is from Sagar Chandrama Hospital. So first case, Dr. Surendra will be presenting the clinical details. I request Dr. Ravishankar and Dr. Sridharmurthy to come to that table to moderate the session. First case will be presented by Dr. Indraja. First case will be presented by Dr. Indraja.
Good afternoon, everybody. The first case is a pathological and clinical curiosity which can be mistaken for other things. So it is just to, I think, give a reminder to all the clinicians that these things also need to be considered before somebody is diagnosed with inflammatory bowel disease or whatever. And so that is this case. So Indraja will present this and we will discuss it as we go on.
Good afternoon, respected teachers and my dear colleagues. Welcome to this month's CRPC meeting. The first case is a 19-year-old young girl presented to the OPD department with complaints of colicky abdominal pain on and off since 1 year. There were no aggravating and relieving factors and it is non-radiating. And also complaints of loose stools 4 to 5 times per day since 1 year. History of blood in stools present, but there was no mucus, and history of loss of appetite and loss of weight was present. On examination, patient looks paler and parabdominal. There was tenderness present in the right iliac fossa. Parectal and examination and proctoscopy showed ulceration in the rectum with mucosal inflammation. There were no hemorrhoids. And patient has been advised with blood investigations and colonoscopy. Initial blood investigation showed drop in hemoglobin and raised ESR, but CRP and albumin were normal. Colonoscopy showed there were ulcers with inflammation in the cecum and rectum. So we thought it is inflammatory bowel disease and we took multiple biopsies. And the histopathology report will be explained by Dr. Ashwin.
Good afternoon, everyone. This is the histopathological image, HND section, showing multiple fragments of colonic and rectal biopsies with the surface epithelial ulceration, and there is a collection of some inflammatory exudate over the ulcerated epithelial surface. So this is the higher power view of the inflammatory exudate, where you can see some ulcerated epithelium and inflammatory cells, some amount of necrosis, and some round structures. Any guess? Yes. These are the classic trophozoite bounds of Entamoeba histolytica. So these are the individual trophozoites where you can see abundant eosinophilic cytoplasm and single condensed nucleus. Only single nucleus is usually present. So, and one more, here, this particular cell, here you can see the RBCs inside the trophozoite. That is called as hemophagocytosis. Usually these trophozoites, they will form pseudopods, which is involved in cell adhesion, then ingestion of the RBCs. So here you can see classical hemophagocytosis, where a trophozoite has ingested RBCs. A higher power view of the same, the trophozoite with a single dot-like nucleus and RBCs inside, hemophagocytosis. This is the ultrastructural view of the trophozoite stage of Entamoeba histolytica. This is the pseudopodium, that is nothing but a temporary surface projection which is involved in locomotion movement and ingestion. So a final histopathological diagnosis of amoebic colitis was made. No, unfortunately, stool routine was not done for this patient. Not done. Yes, cis we can easily see. Yes, sir. Yes.
The other thing is, the features for the right side of the foot, right? I will summarize. Some people are come late. This is a 19-year-old lady who presented with abdominal pain for a year and a half, and with multiple consultations in many hospitals with abdominal pain, diarrhea, some majority of the time 4 to 5 times a day, sometimes 8 to 10 times a day, with blood, but no mucus. And she lost about 8 to 10 kilograms in weight with loss of appetite. And this was the clinical history. And on examination, right iliac fossa was tender. She had lost weight and she looked pale. And rectal examination with proctoscopy showed rectal ulcerations, which were broad-based superficial ulceration with blood. And the mucosa didn't look like classical inflammatory bowel disease where you have mucosal edema with fibrinous exudate and this crypt abscesses and things like that. But it did look like multiple ulcers in the rectum with the intervening mucosa, intervening rectum appearing normal, which was one of the features which suggest that it can't be a classical inflammatory bowel disease, which is why I asked for the inflammatory markers. CRP was normal, serum albumin was normal, hemoglobin was 8.5, and what is the other one? What is the other inflammatory marker? ESR was 55, so that indicates probably chronic infection. And this is the history. And on colonoscopy, rectum, the rectum and just up to the rectosigmoid, there was multiple ulcerations, beyond which the colon was entirely normal, no evidence of any disease anywhere. We went up to cecum, and in the cecum there were again multiple ulcers. This is apparently one of the classical findings of amoebic colitis as opposed to either ulcerative colitis or Crohn's disease. So, and because this lady, she has been going on for some time, she did tell me that she has already had multiple antibiotics and she has had stool examination, which is why I didn't do another stool examination this time.
Do you think anti-amoebic could have been given? That is a common thing with so many.
Yeah, but what she showed me about 4 or 5 prescriptions, all of them are antibiotics. There was no anti-amoebic. Yeah.
Because that's the first thing we treat always.
They were given anti-amoebic. Correct, sir. She's a very educated girl. She's studying the business administration in Delhi. So she had all the prescriptions. All of them were antibiotics. There was no anti-amoebic. Metronidazole or tinidazole, how do you think? Tamil Nadu was normal. Unusual is so much of weight for single for a long time. Just wondering if there's some other underlying disease. And amoebiasis is a co-infection. Actually, maybe, but that's why I told her to we'll give you the full picture. Go on. Earlier stool examination, she said was normal.
After confirmation with histopathological exam.
Yes, madam. It is one of the possibilities, but I don't think tuberculosis having this kind of skip lesions is very unusual. You would get a full scale involvement either just of the right colon, or if even rectum is involved, then you will get three skip lesions in the transverse colon, left colon, and ascending colon, which was not there. Get more of a transverse ulceration. Yeah, yeah. And terminal iron will be important. And another single valve will be important. That's right. The lesson is, I think, a routine stool examination is mandated for any diary. Urine and stool are the most undervalued investigations.
We advise the patient with ultrasound at abdomen and pelvis to look for the liver abscess, but liver there were no abnormalities detected, and there were multiple mesenteric lymph nodes in the right iliac fossa, query lymphadenitis, and mild bowel wall thickening in the right iliac fossa, query colitis, and bilateral polycystic ovaries. After this, we advise the patient with medical treatment, that is metronidazole for 4 weeks. So in the follow-up, patient has resolved with her symptoms. Here I am going to explain the life cycle of the Entamoeba histolytica. It will transmitted by the fecal-oral route by the ingestion of the matured cyst. After ingestion, it will go to the small intestine where the excitation occurs, and the trophozoites will release. These trophozoites enter the large intestine where they will invade the mucosa and enter into the circulation. From there, it will transmit it to the liver, lungs, and brain. And some of the trophozoites, they transform into mature cysts, and that will pass through the feces. Amoebic colitis, as I mentioned, it results from the invasive infection of the colonic mucosa, and it affects approximately 10% of the global population. And it is a major health problem, particularly in endemic areas, and it can mimic the acute phase of ulcerative colitis, causing sometimes misdiagnosis, or sometimes it may coexist with ulcerative colitis, where we miss this diagnosis. It also exacerbate the symptoms and adversely affect the course of ulcerative colitis. So it must be differentiated from other causes of abdominal pain, acute or chronic diarrhea, and weight loss. Amoebic colitis, it classically affects the cecum and ascending colon and forms multiple punctate ulcer with intervening normal tissue. On a histological examination, it shows a flask-shaped ulcer. In severe cases, the ulcers may coalesce to look like ulcerative colitis. It can be managed with luminal and tissue amoebicides. Tissue amoebicides will be used in invasive amoebiasis, and luminal amoebicides for non-invasive infection. Thank you, sir.
So the major issue is that if, for example, you treated this as ulcerative or inflammatory bowel disease, started the treatment with steroids or anything, then it can precipitate the toxic megacolon and very severe augmentation of the disease. So that is why it is important to get the diagnosis before you start treatment. So that is one of the, and amoebic colitis is one of the classic mimics for inflammatory bowel disease. There are any number of case reports and small case series which indicate that patients being treated for years together as ulcerative colitis with no resolution of symptoms. After they were treated with the anti-amoebic treatment, their symptoms resolved. But as Dr. Vijay Kumar said, it could be one of the things which you have to be careful, whether it is due to immunosuppression that this has happened, and you still have to be careful about it. You've seen the other bit part. Patients treated for amoebic colitis have turned out to be inflammatory bowel disease. That's the commonest. For 2 years, we used to see in college days, amoeba mass in the right hand. That's very uncommon now. Hardly seen. I don't think we see that. You have to answer that question. No, we practice that mask. Because surgical things sometimes get mask in the right hand. I have not seen any in the last 20 years. That single amoeba that mask in the right hand. So I just ask the surgeons if they have seen any confirmed amoeba in the right in the no, sir. No. But coming back to this girl, yes, sir.
Surgeons and surgical postgraduates do not operate on it. They dissolve the anti-amoebic.
So this girl has now regained her weight. Her symptoms are gone completely, and there are people who are known to me. So I told them to come for regular follow-up. just to make sure that we keep an eye on things and make sure that it doesn't turn out to be inflammatory bowel disease. But because if you see the inflammatory markers, see the C-reactive protein, albumin, they were all normal, which again indicated to me that it may not be inflammatory bowel disease.
Yeah, but yes, this to follow up, and she doesn't gain weight. We need a repeat colonoscopy to make sure it's seen completely.
Yeah.
Number one, that's very important. All this later, I have not seen so many anemic riders in my lifetime, but not so much of weight loss. This is going on for too long. The other things, especially in invasive areas, there's always immunoglobulin deficiency or retrovirus, some invasive amoebiasis, normally does the patient with immunosuppression. Unless we have.
Thank you. Thank you. See, the other thing is when there is a long-standing amoebiasis like this, there could be potentially liver abscesses. So you need to scan them and make sure there is no liver abscess. So that is another important thing that we need to know. Yes, madam.
From pathology point of view, have you picked up this on microscopy? It's very rare.
Not very rare, sir, but not very common also. Maybe once after I joined here, this is the first case. Maybe once or twice a year. That's it. Not very frequently. I've seen liver abscesses also where they've aspirated and the fresh sample was sent and we have visualized the movement under microscope.
Yes, madam. Yeah, I agree, madam. See, I identify amoebic liver abscess is a classic clinic of hepatocellular carcinoma. So that is another thing you have to always, if you have given the treatment and there is no resolution, follow ultrasound, possibly follow CT scan has to be done. And if there is no resolution, you then have to think about HCC, no doubt. But this girl, lymph nodes are only in the recently, the right colonic recently where the disease was, and all that has resolved. Post I have got a repeat ultrasound scanner, all of that has resolved.
What size of the abscess can you resolve it conservative treatment?
I'm not sure whether there is any size which, sir?
This is less than 4 centimeters. Then perhaps push it up to 6 centimeters. But beyond 6, you won't see it.
Then you have to wait.
We'll move on to the second case. This case was operated by Sridhar Murthy sir in Sagar Chandrama and was reported here. So this is presented by, clinical part is presented by Dr. Sridhar. He's a consultant, Surender. He's a consultant pediatrician in Sagar Chandrama. Thank you for coming here and participating in our program.
Very good afternoon to one and all. I'm Dr. A very good afternoon to one and all. I'm Dr. Surendra, consultant pediatrics from Sagar Chandrama Hospital. I'm representing my team headed by Dr. Ambika, senior consultant neonatology and pediatrics, Dr. Sridhar Murthy, senior consultant pediatric surgery. Greetings from our hospital. I'm here presenting a 32-week female baby born by LSCS, indication being preterm in labor on 24 Jan 2023. Baby weighed 1.76 kg and the amniotic fluid was mechanism straight, but the baby was vigorous and the baby was having good Apgar scores. Baby did not require any. Hello. Baby did not require any oxygen therapy in the NICU. Feeds were initiated on day 2 of life and they were gradually graded up and full feeds were reached by day 5 of life. IV antibiotics were administered for 5 days and stopped as the blood culture and the sepsis screens were negative. So the baby had a pretty uneventful course in the NICU and the baby was discharged on day 12 of life. On day 12 of life, when the baby got discharged, on the very same night, the baby had passed orange colored stools. This pic was sent to our NICU team, and the caregivers were promptly advised to visit the hospital. But the caregivers didn't heed to our request, so they persisted to stay at home. On day 13, also, the baby continued to pass orange colored stools. On day 13, 9 p.m., baby passed blood in stools, so hence the baby was rushed to our Sarachandrama hospital. At 9:50 in our NICU, baby again passed blood in stools. Baby was on examination on arrival, baby was alert, active, baby was not irritable. Vitals were stable, pulse, BP, CRT, all were normal. And evidences of any other signs of bleeds like petechial rashes, ecchymosis, and they were not seen, and there was no bleed from any other orifices. Per abdomen examination revealed soft, mildly distended abdomen with very tenderness and sluggish bowel sounds were present. So our differentials were sepsis coagulopathy, necrotizing enterocolitis, multisystem inflammatory syndrome in newborn, and surgical causes such as malnutrition leading to volvulus, gangrene, and then bleed, and arterial malformations. So coming to the course in the hospital, the baby was started on IV fluids, IV meropenem, and amikacin on admission. Pediatric surgeon opinion was sought while the baby was investigated. The coagulation profile revealed PET of 18.3 and APTT of 47.3. Sepsis screen, that's the total count, CRP and procalcitonin were normal. So the abdominal X-ray revealed distended bowel sounds, and MIS and workup also was sent. At 11 o'clock, Dr. Sridharmurthy sir, he reviewed the case, and in front of him only the baby passed a huge bout of blood per rectum. So hence the baby was posted for emergency expedited laparotomy in view of suspected malnutrition of gut with midgut valvulus. On opening, the gut was found to be non-gangrenous and its perfusion was intact. On careful examination of the gut, the right ascending colon, including the hepatic flexure, was found to have a mass which was spongy in consistency, and it was noted to have active bleed. So, hence, the right hepatic colon, colon along with hepatic flexure and the terminal ileum were mobilized. Right hemicolectomy was done. End-to-end ileocoeliac anastomosis was done in single layer. Mesenteric rent was used, and the gross specimen looked like very hematometal lesion. This is the gross specimen on dissection. On dissection, sorry.
Bottom table before the second. What are the clinical? What are the impression? Getting the all the hamartoma, maybe more the colon part of the I agree. I'm not delaying that. I'm not against the. This is the part of the table. What is sponginess? What is that?
Yeah, we received a right hemicolectomy specimen, which was measuring about 4.5 to 5 centimeter in length. The mucosa was nodular. There are multiple small nodules with the hemorrhagic spots over the nodular surface. So then cut section through the nodules showed multiple cystically enlarged spaces just below the mucosa. So this is the H&D section. Here you can see full thickness. This is the epithelium mucosa. Then this is the submucosa. Then here muscularis propria and subserosa and serosa. So here you can see, especially in the subserosa, multiple dilated vascular channels of varying sizes. So here one more picture showing multiple dilated vascular channels in the submucosa, and also here you can see some thick-walled arteries admixed with the dilated veins in the subserosa. So one more picture showing dilated vascular channels throughout the wall. That is in the submucosa, here in the subserosa. So this is the dilated vascular channels in the mucosal aspect. So this is the submucosal dilated vascular channel. This is the mucosal vascular channel. So here you can see a combination of dilated arteries and veins in submucosa. Again, one more picture showing combination of dilated arteries and veins in the subserosa. The arteries usually will have thick tunica media. So one more picture showing the combination of veins and arteries. Here you can see dilated vascular channel reaching up to the surface epithelium. I think that has probably led to the bleeding manifestation. This is a submucosa adjacent to dilated vascular channel showing some foreign body type giant cell reaction. So this is the proximal margin. So here mucosa is absolutely okay, but again submucosa and subserosa, that is again showing similar dilated vascular channels. So even the distal margin also shows dilated vascular channels in the subserosa. So a final histopathological diagnosis of arteriovenous hemangioma, according to latest WHO classification, it was made. So here, this is the latest WHO classification, where you can see the arteriovenous malformation or arteriovenous hemangioma. Now it is considered as a benign vascular tumor. Arteriovenous hemangioma or malformation is now considered as a benign vascular tumor. So there is one case report. A three-month-old baby with a similar clinical finding and surgical intraoperative findings, where you can see same gastrointestinal hemangiomas infiltrating adjacent structures and solid organs. So it is usually called as diffuse hemangiomatosis. So all together we can say this gastrointestinal hemangiomas, they can be either polypoidal or infiltrative in nature. They can be solitary, multifocal or diffuse. The commonest site is usually small intestine, followed by colon. Then something called as gastrointestinal hemangiomatosis. This is usually diffuse infiltration of intestinal wall, mesentery, and occasionally retroperitoneum, and rarely some of the adjacent solid organs. So this diffuse hemangiomatosis can be associated with some of the syndromes. So our case, it is definitely infiltrative in nature. There is a transmural infiltration of dilated vascular channels, but we really don't know whether it is multifocal or multifocal and diffuse hemangiomatosis. Okay, so for that, I think thorough investigation, including other abdominal. Yeah. Okay.
Sir, the question now we hear is, now that he said that the margins are also.
Next slide, I think we'll.
Then in future of. You know,
we have done certain things after that.
So it's okay, adequate margin. We move on. We don't have much liberty in the. So maybe we can
Sir, and what question, sir? Or if we have a situation of very malformation, you have to ensure margin clearance and likely to do for a tumor, or you accept that in case in future they may bleed and then deal with it. We deal with it macroscopically, so study. This can be multi-distributed to other lesions or certain microscopic areas in the margin.
Since baby is on table, since baby is on your board, at a later date, they can have multiple other AV malformation, when they present later. AV malformation, generally they present to the of birth. Meningioma can present at a later date, and maybe 1 or 2 weeks. There are no meningioma, AV malformation at the time of birth, it won't present in the. But meningioma can present.
Madam, the threat is equated to a tumor. Here, what is the cell of?
No, sir, I never told
It is
it.
a dilated vessel.
I didn't tell
It
you.
is dilated vessel, dilated.
No, sir, they are.
You should ask the person.
If you call it as a. What is your problem? Maybe you know, you equated to.
No, that was presented by the pathologist.
Sir, they are all classified as PPC hamartomas, which is actually tumor. It is just extension of normal. But now the WHO classification is they are included in the. Yes, madam.
Yes, sir. Yes, ma'am. I'm yet to go along with it. Ma'am, I'm yet to present, ma'am. I'll just go on.
Sir, one more question for you. See that this, I know this is difficult, I'm not trying to criticize, I'm just saying, baby came to you and you straight away started meropenem and this one.
No, sir, baby.
White cell count was normal and your other implement was normal and you started symptom meropenem.
True,
What's
sir.
it required?
True, sir. Like, see, sir, like, it's a preterm baby. Baby was there in NIC for a week or so. And the initial presentation, when the baby presents with symptoms of bleeding per rectal, the first diagnosis in a preterm baby will be necrotizing enterocolitis. And baby was already receiving one first line of antibiotics. Our second line or second but third line was meropenem amic acid. So we initially started the baby on that. So on receiving the counts and the other inflammatory marker, if you can observe the baby had come to our setting in for hospital. 9 o'clock was the event, 9:50 the baby was received. 10 o'clock the baby was loaded with the antibiotic, 11 o'clock the surgery had happened. Once he received the counts, it was de-escalated.
Is there any role for ensure?
On table.
No, sir. Sir, the presentation is the key here, sir. Here the diagnostic premodality comes, challenges come. See, the same case if it are present in the pediatric age group, and definitely we have gone through all these routine tests like going for MR angio or a CT angio to look for what's happening, or any transducer study, RCB, RBC studies. But here the presentation is a 32 weeker, sir. For all the 32 weeker with the corrected gestational age of 34 weeks. Our first rational instinct would be to think of neck sepsis, and the third one post-COVID is MASN. Yes, sir. Like now the after. Yes, sir. So we had actually done ultrasound abdomen to rule out any other masses in the abdomen. And since hemangiomas can occur even in the CNS, we have advised for MRI with contrast, which the patient is due for it on follow-up. So I'll just continue the.
I just on table anything more you could have done, sir? Like colonoscopy or something? To rule out sleep lesions?
So 1.1 kilo maybe actually bleeding.
No, once resected. After resection.
1.1 kilo.
I'm asking. I'm not. It's not required.
Post-operatively, the baby was ventilated for 12 hours and extubated.
Just a minute. See, I think Sir Lakshman sir will agree. The on-table colonoscopy becomes an issue when in patients who have significant bleeding, where you have not been able to identify the source of bleed. Once you have already done preoperative endoscopy, colonoscopy, and then you explore because the patient continues to bleed, then on-table colonoscopy or on-table endoscopy is a very, very good diagnostic tool. But here they found the lesion, so they will have to do it.
Post-operatively, the baby was ventilated for 12 hours and extubated. Baby was started on TPN, that is aminoven and lipids, while the baby was NPO. On day 18, that is post-op day 5, the baby was started on OGT feeds and feeds were gradually graded up as tolerated. On day 21, the baby reached full feeds and DBF and Prada feeds were initiated on day 22 of life. On day 24 of life, that is 10 post-op day, the baby was discharged home. Coming to the review of literature, infantile hemangiomas are benign vascular tumors that can affect 5 to 10% of infants. They can present as isolated skin lesions and visceral localization also. The most infantile hemangioma present as isolated skin lesions, and less frequently they have visceral localization. Liver being the most commonly affected organ, although they can also be located in the central nervous system and gastrointestinal tract. The most common anatomical site of infantile hemangioma that can affect the gastrointestinal tract are the intestinal colon and rectum, although they can occur in any segment of the intestine. So the diagnosis depends on the age of the patient, anatomical location, and the presenting symptoms. The most frequent manifestation of gastrointestinal infantile hemangioma is digestive tract bleeding, and its severity depends on the anatomical site where it is found. It can present as melena, hematochezia, and also can cause chronic anemia and may require blood transfusion. In children, GI hemangiomas are an infrequent cause of GI bleeding, and primarily due to its low frequency. So its diagnosis depends on high suspicion. So gastrointestinal hemangiomas can occur in association with symptoms such as Maffucci syndrome, Keppel-Tronay syndrome, and benign neonatal hemangiomas. Incidence of intestinal hemangioma is low, and it basically manifests as GI bleed. So concluding, it's important to consider intestinal hemangioma within the differential diagnosis of the gastrointestinal bleed of all the patients in whom etiology is not clear, or after excluding the prevalent pathologies in children. Although infantile cutaneous hemangiomas are common, infantile visceral hemangiomas are fewer and can present with significant diagnostic challenge. Thank you. Sure, sir.
Any clarifications are out?
Ma'am, usually they're benign, ma'am. Please. Ma'am, most commonly the cutaneous hemangiomas, they are associated with, as I told you before, Maffucci syndrome. They can have hemangiomas involving the cartilage, tumors involving the cartilage bone, and they can also co-present with hemangiomas. And the other Keppel-Tronay syndrome, they can have even the lymphatic vessels involved in it. These are the most commonly seen. Yeah, as I agreed, like they need to be followed up. And apart from that, we need also to investigate. We are still, the investigation is pending, ma'am. The patients are not that affordable. So on follow-up, we're planning for an MRA of the brain to look for any other hemangiomas.
What is the difference between hamartoma and angiomyelite? Angiomyelite and hamartoma. In the AV malformation, whereas the angiomyelitoma is.
That is also like a hamartoma. In the neoplasm, where you can see proliferation of three components, usually vascular and smooth muscle.
Tissues.
which is characterized by certain markers called HMB45 and actually melanoma marker. The diagnostic feature is anti-melanoma, which show HMB45. That is the diagnostic and it's a low class, totally different. This blood mutation pattern and
I don't know, many of you would have realized, we had a case in the first week of this month. The hospital, massive change of my life on first patient was adult. And we did not have a blood bank. We had given 40 units of blood. We did it. Embolization did to come for an emergency, definitely in the middle of it. I don't know, school that doesn't get in now, was critical.
Any other questions? I just forgot to mention the with amoebiasis and inflammatory bowel disease. I think other things like Campylobacter jejuni and also giardiasis and spondylitis cercoralis. These are infections which can mimic inflammatory bowel disease, and all of these things have to be kept in mind when we have patients with diarrhea and colonoscopic findings of ulceration. Actually, when I attended a surgical update in Manipal in 1991, they had done a fortunately they had done a restorative proctocolectomy, and in the final histology of the colon, they found spondylitis cercoralis, and that was the reason the patient had chronic diarrhea. It was not ulcerative colitis at all, but fortunately, at least they have done a patient is still able to pass motions all natural rather than having a ileostomy, which is only the it's a small consolation, but this is something we have to keep in mind. So unless you have histology, you do not treat inflammatory causes. It is very important.
Thank you. Thank you.
We have come to the end of the meeting. Thank you all. Thank you, Dr. Ambika and Dr. Surendra, for sir also for participating in the meeting. Thank you all.